Okay, this is part 2 of 2/27/2020 Thursday NPTE prep with Final Frontier. I know my hair looks crazy today. I don't know if you can see it in the video because I'm going to be going to slideshow view in just a second, but I did Therapy Ed 2018, 336 to 337 early this morning, and added in some of the acquisition skill booklet that I acquired. Ooh, pretty red bird. Acquired, sorry about that, during my advanced pediatrics class. Um, so this time we're going to do Therapy Ed 2018, 340 to 341. And this time I'm going to be adding inserts from my PEDS Rehab Notes, Evaluation, Intervention, and Pocket Guide book. This is the motor development, motor milestones. This breaks it up by age and domain of development in the first year. So age 0 to 1, and repetition is the best way to learn. So this is kind of repetition of what we did in part 1, but 0 to 1 month. The gross motor skills is lifts, rotates head, kicks symmetrically. Let's go to slideshow, make this big. I think I like that better. Okay, rotates head, kicks symmetrically. The fine motor is open and closed hand, may attempt to reach. Oromotor, motor, routine and suckle pattern for gaining nourishment. Because of my cerebral palsy, sometimes some words are hard for me to say, so bear with me. 2 to 3 months, decreased head lag with pull to sit, begins prop on elbows, prone, reaches and grabs, poor control of release, hand to mouth, control of suck, swallow, breathe with breastfeeding or bottle feeding. 4 to 5 months, hand to feet play in supine, attempts roll to side, may sit with support, may push up on extended elbows in prone. Palmar grasp, can hold a toy with 2 hands, 4 to 5 months. First textures, if able to hold head erect in semi-reclined sitting position, may initially show tongue thrust. 6 to 7 months, sits without support, may achieve hands and knees, rolls supine to and from prone, attempts belly crawling, rakes for small objects, can hold object in palm using fingers and thumb in a radial palmar grasp. So here we have poor control of release, palmar grasp, 4 to 5, radial palmar grasp, 6 to 7 months. Holds bottle for drinking, may start finger feeding, easy dissolving cookie or cracker, vertical chewing. 8 to 9 months. Transitions in and out of positions, may pull to stand, crawls, attempts creeping, developing controlled release of objects, and uses radial distal grip. Uses top lip to clear food from spoon, uses tongue to lateralize food, and uses a sippy cup. 10 to 11 months. Cruises on furniture. May walk with hands held, creeps rapidly, stands alone briefly. Developing inferior pincer grasp. thumb and middle of index finger. Chews soft to firm foods. Keeps most in mouth, swallows without choking. 12 months. Rises to stand through hands and knees. First independent steps. Lowers self with standing. Lowers self from standing with control. Developing fine pincer grasp. Tips of thumb and index finger. So we go from thumb and middle of index finger, inferior pincer grasp, to tips of thumb and index finger, fine pincer grasp. Spoons, scoops with a spoon, finger feeds well, chews and swallows firmer foods without choking, rotary chewing. This is the World Health, can't talk this afternoon, World Health Organization windows of achievement of 6 major motor milestones. So as you see right here, we have 3 to 9 months, so 4 to 9 months sitting without support. Standing with assistance, 5 to 11 months, 12 months. Hands and knees crawling, we're looking at about 5 months to 13 months. Walking with assistance, we're looking at 6 months to 13, 14 months. Standing alone, we're looking at 7 months to 16, 17 months. Walking alone, we're looking at 8 months to 17 months. So a year and 5 months. So walking alone can go anywhere from 8 months to a year and 5 months. So there's quite a range there. Okay, key motor milestones by age and domain of development, toddler and early elementary school age. So 18 months are creeping up and down steps, getting to run stiffly. Begins to scribble, uses palmar supinated grip on utensil and plays with shape sorter. 2 years, uses railing on steps, jumps off small step, kicks a ball. Tries vertical and horizontal strokes, uses digital pronated grip on utensil, able to do simple puzzles. 3 years, rides a trike, a true run, alternates feet ascending stairs, jumps over small objects. Able to copy a circle, stacks 10 blocks, undresses self, strings large beads. 4 years, alternates feet descending stairs. Throws ball overhand with some trunk rotation. Catches ball by trapping. Gallops. Able to trace a diamond, copies a cross. Uses static tripod grip of utensil. Cuts straight line with scissors and brushes teeth. 5 years. Hops 8 to 10 steps on 1 foot. Can hit target with ball from 10 feet. Balances 1 foot 10 seconds. Skips. Walks on balance beam. Able to copy a triangle. Uses dynamic tripod grip on utensil. Writes letters and numbers. Buttons, small buttons. Prepares simple breakfast. Catches balls well. Manages most of self-care. 6 to 8 years old. Plays hopscotch. Can use skates. Rides a 2-wheel bicycle. Jumps rope. Can hit a ball with a bat. Jumps down several steps. Able to manage a zipper. May tie shoes. Copies a diamond. Uses scissors to cut shapes. Greater control and refinement in writing. Manages all self-care, prints well, and may write in cursive. Okay. Full-term newborn, infant, and child examination. APGAR screening test. Administered to newborns at 1, 5, and 10 minutes after birth. Continues every 5 minutes if infant is having difficulties. It measures or screens 5 items: heart rate, respiration, reflex irritability, muscle tone, color, and each are scored a 0, a 1, or a 2. A score of 7 and above is considered good. Neurological examination of the newborn. Assign states of consciousness. Test newborn reflexes. Neonatal behavioral assessment scale. Test interactive self-organizational abilities and newborn reflexes and muscle tone. Skeletal system examination. Fractured clavicle. Dislocated hip. Asymmetrical gluteal folds, hip click. Spine. Is it curved? Inflexible? Do they have kyphosis, scoliosis, spina bifida occulta, a dimple, patch of hair, pigmentation visible, and X-ray verification? Checking for clubfoot. Ankle in plantar flexion, forefoot adduction, and supination. Equinovarus. Talipes equinovarus. Range of motion. Number 5. Newborns have decreased range of motion into extension due to physiological flexion, but increased dorsiflexion of ankles and flexion at wrist. Newborns have decreased range of motion into extension due to physiological flexion, increased dorsiflexion at the ankles and flexion at the wrist. Posture, physiological flexion of all 4 limbs due to position in utero, head to one side. Movement, spontaneous and reflexive. Occasional tremuluousness normal. I don't know what that word means. But here's a picture of common postural dysfunction and deformities. Kyphosis, scoliosis, and pigeon breast, and depression in chest. Tibial femoral angle, your newborns, moderate genuvaran, approximately 15 degrees. 1 to 5 to 2 years, 1.5 to 2 years, neutral knee position. By 2 years, peak of physiologic genu valgus, 10 to 12 degrees. And then by 7, adult-like position with mild genu valgus, 5 to 6 degrees. So we go varum, neutral, valgus more than adult, and then it decreases by 7. Neonatal reflexes, primary motor patterns and infant reflexes and reactions. Now I'm not going to read this slide because I'm going to go into each one independently on one slide. So there's another one. There's another one. Okay. So, neuromotor development and sensory integration. This is a table that shows blue typical timing, and yellow, diminishing response. Okay? So, sucking, touch to lips, tongue, palate results in automatic sucking, 0 to 6 months, important feeding reflex. So the other book that I got this out says 0 to between 2 and 3 months, and then it starts diminishing 3 to 6 months. So 0 to 6 months. Rooting, stroking of perioral region results in head turning to that side with mouth opening, 0 to 3 months. Important feeding reflex. Oops. So rooting 0 to 3 months. It diminishes it during the 3rd month. Gallant or trunk incurvation reaction. Sharp, stoke, along, probably means stroke, along perivertebral line from scapula to top of iliac crest results in lateral trunk flexion toward stimulated side, 0 to 2 months. So gallant, 0 to 2 months, and it starts diminishing in the 3rd month. Okay, now here's the gallant. Okay, stroking down. It says stoke, but it probably means stroke. Along the paravertebral line from the scapula to the top of the iliac crest results in lateral trunk flexion toward the stimulated side. So paravertebral. Stroke skin over paravertebral area. The curvature of trunk on side that is stroked. The gallant. Rooting, stroking the perioral region results in head turning to that side with mouth opening. And these are primitive reflexes. Okay, the rooting is going to start at birth and go until about the 2nd month and start dissipating in the 3rd month. So you stroke the perioral area when hungry, and the response is turns head and opens mouth towards stimulus. Palmar grasp. Pressure stimulus against palm results in grasping of object with slow release, 0 to 4 months. 0 to 4 months, diminishes in the 4th, 5th, and 6th month. Plantar grasp, pressure stimulus to sole or lowering of feet to floor, results in curling of toes. Must be integrated before walking occurs. So plantar 0 to the 3rd month, and then at the 3rd until the 6th month it starts dissipating. Palmar grasp, pressure placed in the palm of the hand, flexion of the fingers. Pressure placed on the sole of the foot, ball of foot at the level near the metatarsal heads, flexion of the toes. Plantar grasp. Moro reflex. Sudden extension of neck results in flexion, abduction of shoulders, extension of elbows, followed by shoulder adduction and elbow flexion. Usually also results in crying, so test last. 0 to 4 months. Moro reflex, 0 to, they say 4 months in Therapy Ed. My other book says it goes until 6 months. Primary standing reaction. Infant held in supported standing position supports some weight and extends lower extremities. If this reflex persists, will interfere with walking by causing extension of all joints of the lower extremity and preventing disassociation of flexion and extension. Primary walking. Hold infant in supported standing, tilt trunk forward slightly, reciprocal stepping motions in lower extremities. 0 to 2 months unless practiced. There's your stepping, supported standing, stimulus, support in standing, feet in contact with surface, and shift weight forward. Rhythmic, alternating step-like movements, mostly a function of hip flexion. Moro reflex. Sudden extension of neck results in flexion, abduction of shoulders, extension of elbows, followed by shoulder adduction and elbow flexion. So a quick neck extension, the head drops back about 30 degrees. The baby extends and abducts arms, fingers, splay, like they're scared of falling. May be followed with arm flexion and adduction. Moro. Now we're to the symmetrical and asymmetrical tonic neck reflex, ATNR, STNR, and then your tonic lateral, I can't say that word, reflex. Classic. Okay, so let's see what we got here. Let's just move on to the individual slides. Asymmetrical tonic neck reflex. Rotation of head results in extension of face side extremities. So you turn, so we're extending the face side extremities and flexion of skull side extremities. So when you turn your head, you're extending the face side and you're flexing the arm on the skull side. So bam, like you're gonna pull a bow and arrow. Asymmetric tonic reflex. Stronger in lower extremities of neonates 0 to 5 months. If reflex persists, may result in scoliosis or hip dislocation and interfere with grasping and hand-mouth activities. So appearance the 2nd to the 4th month here, ATNR. And the therapy is at 0 to 5 months. Symmetrical tonic neck reflex. Extension of the cervical joint produces extension of the upper extremities. Extension cervical, extension upper extremities. And flexion of the lower extremities. So the neck and the upper extremities both extend and the knees flex and the hips flex. Flexion of the cervical joints produces flexion of the upper extremities and extension of the lower extremities. So the neck and the upper extremities are going to do the same thing, and then the lower extremities are going to do the opposite. And this is 6 to 8 months, and my other book says 4 to 12 months. If the reflex persists, it may interfere with development of stable quadruped positioning and creeping. Let's go up here and read this. Persistence of primitive reflexes, such as these listed here, is thought to be a possible sign of central nervous system dysfunction and may help to identify early signs of several conditions, including cerebral palsy, autism, Asperger's syndrome, and speech dysfunction. Persistence of these reflexes may also interfere with the development of postural control, mobility, and achievement of motor milestones. Okay. I am going to see if I can figure out how to say this blasted word. But this is the slide on writing reactions. Labyrinthine.
Labyrinthine.
Labyrinthine. Labyrinthine.
Labyrinthine.
Labyrinthine. Labyrinthine.
Labyrinthine.
Labyrinthine. Okay. Optical and labyrinthine writing. Head orients to a vertical position when body is tilted. Head orients to a vertical position when the body is tilted. So when the body is tilted, the head goes like this. Right? Test labyrinthine writing with the eyes blindfolded. 1 month throughout life. Body writing reaction acting on the head. So body on head. Contact of body with solid surface results in head writing with respect to gravity. Interacts with labyrinthine writing reaction on head to maintain orientation of head in space. Begins at 4 to 6 months and persists throughout life. Landau's reaction. Infant held in ventral suspension will extend neck, trunk, and hips. I think I put each... Nope, I didn't. I thought I put each one on, but I didn't. Okay. A neonatal neck writing on body, so neck on body. Turn head with infant in supine position. Body log rolls towards same side, 0 to 6 months. Body writing reaction acting on the body, body on body. Rotation of head and thorax results in rolling over, with rotation between trunk and pelvis begins 6 to 8 months. I'm going to take a break right here. I'll be right back. Okay, I'm back. I went and found a pretty cool video. Let's look at this video.
Hold the baby so that you can better see. The first reflex is labyrinth head writing. The position is vertically hold the baby. You're supported in space and the baby should be blindfolded. The stimulus is swing the body away from the vertical position. The response should be head writing. The next reflex is optical writing. The position is to hold the child in an upright position. The stimulus is to tilt in all directions. The response is for the child to attempt to write head against gravity.
The next writing and equilibrium reaction is body writing acting on head. The position of the baby is going to be in prone. The stimulus is allowing the chest to contact the supporting surface, and the response of the baby is to attempt to right the head vertically with neck extension against gravity. That is body writing acting on head. Writing equilibrium reaction is neck writing acting on body. The position of the baby is going to be in supine. The stimulus is turning the head to either side, and the response is a segmented roll superior to inferior, starting with the shoulders. Now again, we're going to demonstrate on a person. The person is in supine position, turn the head to either side, and a segmented roll superior to inferior, starting with the shoulder. And that is neck writing acting on body. Writing and equilibrium reaction is body writing acting on body. The two positions in this are supine and prone. In supine, the stimulus is going to be flexing the knee towards the chest and across the body, which causes a segmented roll inferior to superior. In prone, The stimulus is going to be to place the hand under the hips and pull gently back. And they're also going to have a segmented roll, inferior to superior. Now to demonstrate on a person. And supine, it reflects the knee towards the chest and across the body, which causes a segmented roll, inferior to superior. In prone, place the hand under the hips, pull gently back, and a segmented roll, inferior to superior, will take place. And that is body equilibrium reaction is Landau. The position you'll have the baby in is prone and supported under the trunk. The stimulus is going to be suspending the infant horizontally, and the response is going to be called the Superman, which is extending all extremities. Now to demonstrate on a person. Support the infant horizontally, and the infant will extend all extremities, and that is Landau. Providing equilibrium reaction is positive support of the lower extremities. The position of the child will be supported in a vertical upright position. The stimulus is to allow the feet to contact the surface, and the response is the child supports themselves through their feet. And that is positive support of the lower extremities. Providing equilibrium reaction is positive support of the upper extremities. The position of the child will be in ventral suspension. The stimulus will be allowing the hands to contact the surface, and their response will be supporting themselves through their hands. And that is positive support of the upper extremities. Providing equilibrium reaction is visual placing. The position of the child is going to be supported ventrally. The stimulus is to lower the child towards a flat surface, but don't actually touch the surface. And their response will be the arms and legs extend to bear weight. And that is visual placing. The next three riding equilibrium reactions are protective responses of the upper extremities. The first is forwards. The position is ventral suspension, sitting, or kneeling, and this will do sitting. The stimulus is going to be displacing the center of gravity forward with a sharp push, and the child stops their falling with shoulder flexion, elbow extension, wrist extension, and finger abduction. The next is protective responses of the upper extremity sideways. This will be sitting. The stimulus will be displacing the center of gravity sideways with a sharp push, and the response is going to be abduction of the opposite shoulder and elbow extension, and extension and abduction of the fingers on the contralateral side. The next is protective responses of the upper extremities backwards. This will also be sitting. The stimulus is going to be displacement of the center of gravity backwards, and the response is going to be hyperextension of the shoulders, extension of the elbows, wrist extension, and abduction of the fingers. And those are the protective responses of the upper extremities: forwards, sideways, and backwards. Now to demonstrate on a person. The first is forwards. The next is sideways. And the last is backwards.
The next reflex is protective response of the lower extremity downward. The position is to suspend the child in vertical upright position. The stimulus is to quickly lower the child toward a flat surface. The response should be extension and abduction of hips, extension of knees, and ankle dorsiflexion. The next reflex that we'll be doing is the protective staggering reaction. The position is standing. The stimulus is to quickly push or pull into an unbalanced position. And the response is to take steps to regain balance. The next reflex that we're doing is a protective shift reaction. The position is standing. For the stimulus, you hold the hand and foot on the same side, flex the knee and hip, and pull the hand sideward. The response should be flexion and abduction of the ipsilateral hip, extension of the ipsilateral knee, and the child should step to the side. The next reaction is the amphibian reaction. You hold the child prone with the head in midline, arms near the head, and hips and knees extended. For the stimulus, you lift one side of the pelvis, and the reaction should be flexion of shoulder, hip, and knee on the ipsilateral side.
Oh, that was pretty funny, wasn't it? Yeah. Oh, they got all kinds of stuff in here. Okay, so let's go back to the PowerPoint. Okay. Where are we? So we use that PowerPoint to, let me get that out there, to do optical and live Rheinstein. I already forgot how to say that word. Bod riding reaction, acting on the head, Landau's, neck riding on body, and body riding reaction on the body, BLB. Okay, let's move on. Parachute, lower extremity, parachute, upper extremity. I think that's what they were doing. Protective extension, quick displacement of the trunk in downward direction while held or while sitting in forward, sideward, or backward directions result in extension of the legs downward and extension of the arms in sitting position to catch weight. Downward begins at 4 months, sideward begins at 6 months, and forward sitting at 7 months. Backward sitting at 9 months. These reactions persist through life. So downward 4, sideward 6, forward 7, and backward 9. So it goes downward, sideward, forward, and backward. DSFB. So DSFB. That's the order. So downward, side, oops, didn't want to do that. Go back up there. So downward, sideward, forward, and backward. Okay. Postural fixation, tilting reactions, slow shifting of base of support or slow displacement of body in space will result in lateral flexion of the spine towards the elevated side of support, a reduction of extremities on elevated side, and sometimes trunk rotation towards elevated side. So postural fixation, tilting reactions. Prone begins at 5 months, supine begins at 7 months, sitting begins at 9 months, and quadruped at 12 months. So we got prone first, then supine, then sitting, then quad. Supine, sitting, quad. Come on. It's not working for me. Okay. So, PS, SQ. Bambinsky reflex stroke lateral aspect of plantar surface of foot, good extension and thinning of the toes. We know about that one. Flexor withdrawal, sharp, quick pressure stimulus to the sole of the foot or palm of the hand causes withdrawal of stimulated extremity. 0 to 2 months, although some sources say present throughout life. Crossed extension, sharp, quick pressure stimulus to the sole of the foot results in withdrawal of stimulated lower extremity and extension of opposite leg. 0 to 2 months. Startle, loud noise, sudden light, cold stimulus causes a sudden jerking of whole body or extension and abduction of upper extremities, followed by adduction of shoulders. 0 to 6 months. Placing reaction, drag dorsum of foot or back of hand against edge of table, get placing of foot and hand onto table. I think those students did that one too. 0 to 6 months. Traction or pull to sit, pull infant to sitting while from supine position, upper extremities will flex and head will lag until 4 to 5 months. So now we're going into the standardized tests. There's 2 types of standardized tests. There's the norm reference test and then there's the criterion reference test. Let's go to a slideshow. So the norm reference test, performance compared to others who took the test or with some other group of students. Versus criterion reference test is comparing students' performance with predefined performance standards. So with the norm reference, you're comparing your test score to other people's test score. With a criterion, you're comparing your test score to the predicted performance standards. With a norm reference, it's relative grading. With criterion, it's absolute grading. Norm ascertains the rank of students. So percentiles out of 100%, for example. And then with the criterion, the student's score is not influenced by other scores. The norm reference examples is the SAT, the GRE, IQ test. The criterion reference is the ACT test. So the norm reference places a student in a percentage category, relates one candidate to that of another. The criterion tells what students can actually do with the language if you were testing language. Possible for all students to get A's if they were able to meet the criteria. Motivates students to perform up to standard rather than trying to be better than other students. So criterion is up to standard. Norm reference is putting all the students who took the test in a ranking. So you're comparing your student to student. And criterion is comparing student to a standard. So norm reference is student to student. Criterion is student to standard. Criterion. The standard is the criterion. The criterion is the standard. So it's a criteria, the standard. The criteria is the standard. So norm reference is student to student. Criterion is student to criterion. Student to standard. Screening test, the Denver Developmental Screening Test 2, to screen for developmental delay. It tests social, fine, gross motor, and language skills from birth to 6 years of age. The Alberta Infant Motor Skill, AIMS, Observational scale for assessing gross motor milestones in infants from birth through independent walking. Okay. So, the Denver Developmental Screen Test 2, it goes from newborn to 6.5 years old. And it's a norm reference test. So what that means is comparing student to student. So it's ranking your student. So it's norm referenced. Let's see, B, it does body structures and functions and activity. Body structures, functions, and activity. The Alberta Infants Motor Scale is newborn to 18 months, year and a half. It's a norm reference, so it's student to student, and it's going to test activity. Gross motor developmental skills in prone, supine, sitting, and standing. Standardized motor test. We have 4 here. Movement assessment of infants, Peabody, gross motor function measure, GMFM, and the BOT2. The moment assessment of infants identifies motor dysfunction and changes in the status of motor dysfunction and establishes an intervention program for infants from birth to 1 year. It's a criterion reference exam of muscle tone, reflexes, autonomic reactions, and volitional movements. So it's criterion, so the baby has to meet a criteria. He can score an A if it meets all the criteria. So it's student to standard. Peabody Developmental Motor Skills assesses gross and fine motor development from birth to 42 months. Includes spontaneous, elicited reflexes, and autonomic reactions. Gross motor function measure, developed to measure change in gross motor function over time in children with cerebral palsy. Also valid to use in children with Down syndrome. All items on the test could be accomplished by a 5-year-old with typical motor development. Focuses on voluntary movement in 5 developmental dimensions: prone and supine, sitting, crawling, and kneeling, standing, walking, and jumping. The Brunin Inc.'s let's just call it BOT2, BOT of motor proficiency, developed to measure gross motor and fine motor abilities in children 4.5 years old to 21 years of age. It's norm referenced on typical children, which means what? It means that it's ranking students, whoever take the test, it's ranking them in order. This student did better than this student did worse than this student, so it's student to student, norm referenced on typical children. Can use full battery or short form for screening. So, newborn to 12 months, movement assessment of infants, muscle tone, reflexes, autonomic reactions, volitional movement, and its criterion reference. So, it's going to, and I think, this is supposed to go down here. I need to fix that. This arrow, oops. Oh, no, it isn't. Movement assessment of infants, that's correct. Standardized motor test. Movement assessment of infants. Okay. Muscle tone, reflexes, autonomic reactions of volitional movement, criterion reference, and its body structures and functions. The Peabody, newborn to 5 years, reflexes, stationary, locomotion, object manipulation, grasping, visual motor integration. It's norm referenced, so it's comparing student to student. It's assessing body structures and functions and activity. The gross motor function measure is 5 years, starts at 5 years old, lying, rolling, sitting, crawling, standing, walking, running, and jumping. And it's criterion reference. It's not student to student, it's student to criteria, so student to standard, and it's assessing activity. The BOT2, 4 years to 21 years old, fine motor precision, fine motor integration, manual dexterity, bilateral coordination, balance, running, speed, agility, upper limb coordination, and strength. It's norm referenced. So norm referenced is student to student. It's ranking the students. Body structures and functions and activity is what it's testing. Then we have sensory integration and praxis tests. Sensory motor assessment for children between the ages of 4 and 9 with mild to moderate learning impairment. Includes tests of balance, proprioceptive and tactile sensation, and control for specific movements. Comprehension development assessments. The Bailey Scales of Infant Development Revision, norm reference motor and mental skills for children from birth to 42 months of age. So the Baileys, 1 month to 3.5. Mental, motor, behavioral skills, subtest for social, emotional, adaptive behavior. Caregiver support screening test is also available. It's norm referenced. So we're doing student to student. It tests body structures and function and activity. Pediatric functional assessments. The PD, interview and questionnaire scale of activity of daily living with or without modification, completed by caregiver. The WeFM assesses function in self-care, mobility, locomotion, and communication, and social cognition. The SFA, school functional assessment, measures participation, task supports, activity performance, physical task, and cognitive behavioral tasks within the school setting. It's for children in grades kindergarten to 6th grade, 5 to 12 years of age, and it's criterion referenced. So the PD, 6 months to 7.5 years, self-care, mobility, social function, modification scale, and caregiver assistance scale. It's norm reference, student to student, and it attests activity and participation. The functional independence measure, the WeFM, self-care, mobility, cognition, training required, national database available, 6 months to 7 years old. It's norm reference, so it's student to student, and it's testing activity. Then you have your SFA, 5 to 12 years. It tests participation, task supports, activity performance, physical tasks, cognitive behavioral tasks. It's criterion reference, so it's student to standard, a criterion. And it tests activity and participation. And here's an extra little slide that I pulled out of that book, patient-client management model, diagnosis, prognosis, evaluation, examination, intervention, and outcomes. Okay, so you have your exam, your history, systems review, tests and measures, your evaluation, clinical judgments based on exam data, and then diagnosis, then prognosis, intervention, and outcomes. And that was the question I had a lot of issues with because I could not find an APGAR scale. It's not in the book. It's not in that reading either. A newborn presented to have symptoms of flexed arms and legs, heart rate of 98 beats per minute, minimal response to stimulation with blue extremities and pink trunk, vigorous cry. According to the APGAR scale, I have no idea. I don't know how to score that test. It didn't give us the information. So, and this is what it said in my book, The Clinical Practice of Pediatric Physical Therapy. Examination. The examination of the newborn begins with a review of the medical record and the observation of the infant in her crib. Any medical diagnosis should be noted as they may impact the evaluation or subsequent interventions. Box 4.1 contains some common medical diagnoses and the related symptoms that can be seen in the infants in the NICU. The medical record may also contain the infant's APGAR scores taken at the time of birth. The total APGAR scores derived from the examination of the newborn's heart rate, respiratory rate, muscle tone, flexibility, reflex irritability, and color, each rated a 0, 1, or 2 at 1 to 5 minutes after birth. The APGAR scale is not used as an indicator for need for resuscitation. Rather, it may be used to examine an infant's response to resuscitative measures. In term and preterm infants, the APGAR score remains a valuable predictor of infants who will need ongoing support in the immediate postpartum period and those who are at higher mortality risk in the neonatal period. In addition, information on the infant's weight and vital signs should also be noted. So as you see, it didn't tell me anything about how to score it. But that is what we were given on the Final Frontier NPTE Facebook group. And this was not taken out of a book, out of a textbook. And so, I don't know. Go ahead, study it if you want. Don't study it if you don't want. But that is the end of, I might add a few more videos. Let's see what time we got here. It's an hour. Let me let Jenny out to go pee and I'll be right back. Okay, so let's look at some videos. This is optical writing. It's not very long, 18 seconds.
He gets his head up and is maintaining it above the plane of his body. He's going to get his legs up too. So he's opposing gravity at this point in time, just like he's going to be on the prone position. So that's good.
So that was optical writing. Let's look at left head writing. So that's left head writing. Okay. Let's see what else we got.
This is the neonatal neck writing acting on the body reflex. So it's 34 weeks gestational age. Integration is 4 to 5 months. It's going to be supine.
This is the Muro reflex. Something. Alright, let's see what else we got. Physical exam. Let's see the stepping reflex. Dr. Lammers actually showed us this guy.
We're going to do the walking reflex and see if he'll take some steps here. Okay. Some steps, very cool. Alright.
Oh my goodness. Bless his little heart. Okay, let's see what else. Tonic neck reflex. Let's see what's going on here.
tonic neck reflex or fencing posture appears at 37 weeks gestation but is most prominent during the first month of age. It disappears at approximately 6 months of age. With the baby in the supine position, turn the head to one side, holding the jaw over the shoulder. The arm and leg on the side to which the head is turned extend, while the opposite arm and leg flex. This response does not normally occur each time this maneuver is performed, and when it is elicited each time it is evoked, it should be considered normal at any age. It will persist beyond the time of expected disappearance in major cerebral damage.
Here's the gallant. That's a pretty good one. I think we're good. Let's look at one more, maybe two.
We're going to go into a land down position. Head comes up, feet comes up. We push the head down, the feet go down. Head comes up, the feet come up. And then we push the head down, the feet go down. Come back up. This is a partial reflex. It occurs and develops at about 5 months of age, so he has that.
They don't like all that testing, do they? Okay, let's see it. I saw one more down here I want to look at. I think. It was there. Where did it go? It was the parachute thing I wanted to see. Aw.
We're going to go into a land down position. Head comes up, feet comes up.
Let's look at this one. Parachute reaction. No response. 3.5 weeks old. No response. Ooh, I like that one. Arms and legs extend, fingers spread. Okay.
Now we're just going to tip him up, catch his arms extended, reaching out to catch himself. That occurs about 8 months of age. He's got well-developed partial reflex. So right now, it's bringing the hands, catching himself.
right, guys. We'll stop there. That's part
Let's try the parachute.
2.
And the parachute, he
And that's
hasn't
it.
the parachute
On
yet.
this one,
And he's too young for
our
the
5
parachute.
minutes.